Good morning. I'm going to present on behalf of Medicine 3. Notes and close. A 52-year-old lady, Mrs. S, housewife from Jharkhand, presented with the complaints of swelling over left arm for the last 9 months and skin peeling all over the body for the past 4 months. The loss of appetite also for past 4 months and excessive fatigue and unable to carry out the basic daily routine for the past 2 weeks. On history of presenting illness, she was apparently well before 9 months. Then she started to notice a small swelling nodule over the left upper arm and the aspect. Initially, it was about 2 in size, which was painless as if left unnoticed. Then the swelling was gradually progressed until the lemon size, with surrounding redness and skin and pain. Changes in the consistency and becomes soft cystic fluctuant with occasional watery discharge from the center of the swelling. Until August 2024, then turned out to an ulcerative lesion. She underwent surgical excision of the same on August 31, 2024. She was treated with multiple antibiotics outside hospital. After 1 to 2 weeks surgical excision, she presented with she developed a scaling and itching over the skin and also the entire body and scalp also involved. Starting from the body, it progressively involved the face and sparing of the oral mucosa. There was a history of gradual loss of appetite, which became almost nil appetite with decreased oral intake also at the last time. In December 2024, she developed an episode of symptomatic hypoglycemia for the far, which she was hospitalized. Following, she had developed a progressive fatigue, which worsened over the past 2 weeks. And she now requires assistance for the ambulation also. And past history, she has a non-with diabetes and regular medication. And his, on the vital signs, pulse rate was 104 and BP was 180. Respirated also 24 cycles with room air and saturation was maintaining at room air. GRB is 85. She was on general examination. She was present with the pallar and breast examination. The induration present in the outer quadrant of the left breast associated with the discoloration of the skin over the area. Fluid orange also was present. Generalized cirrhosis with the ectotic changes all over the body with the skin erosion at the creases. And other system examination are nothing significant, and CNS showing only that power 3/5 with both upper and upper limbs and 2/5 in both lower limbs. This is a reference image. I could not get the image of the patient. She was presented with this dry rough skin with prominent scaling. The symptom complex of a patient: loss of weight, appetite, and pallor and ichthyosis. The normal for the differential diagnosis for malignancy with paraneoplastic ichthyosis. The primary breast malignancy thought of and called genes lymphoma, aplastic large cell lymphoma, and HIV, the autoimmune diseases, systemic lupus erythematosus, dermatomyositis, mixed conditions disorder, and eosinophilic fasciitis, and sarcoidosis. And drugs that causing the ichthyosis: cimetidine, clofazimine, hydroxyurea, cholesterol-lowering agents, nicotinic acid, and tipironol. Our initial evaluation showed CBC, the hemoglobin was 8.8 with the MC of 98.7 and MC is 30.5. The total leukocyte counts were elevated. The difference, the neutrophilic predominant, and platelets are 438, and ASR CRP also was elevated. AFT showed there is an alkaline phosphatase only was elevated. And during the course of this her stay, she developed a hypoxia and tachypnea and hypotension. And EBG showed that metabolic acidosis for the worsening of her condition. She was shifted to ICU and started on the broad spectrum antibiotics after the blood culture. Before the ICU shift, we have done the CT neck, thorax, abdomen, pelvis. So after the shifting to ICU only, the report came out. We found out to be the enlarged left axillary nodal mass was there, and borderline enlarged right axillary and left supraclavicular and mediastinal left velar nodes. A different stranding with the skin thickening over the left breast. Well defined solid nodule seen in the upper outer quadrant of the left breast. And suggestive of UCA for further evaluation, and UCA also we did, it showed a broad lesion in the left breast. So our diagnosis was towards the primary breast malignancy. So and also the patient was also presented with probably the ichthyosis or probably the lymphoma. The patient presented with acute ichthyosis. The differential diagnosis for the malignancy: Hodgkin's disease, non-Hodgkin's lymphoma, and leiomyoma, Hubris sarcoma, multiple myeloma, and autoimmune diseases. And infectious disease also presented with acute ichthyosis: AIDS, HTLV, and leprosy and medications as we discussed before. In the paraneoplastic, the patient presenting with the paraneoplastic syndrome, like skin manifestation ichthyosis, um, we have to conclude this. There is a skin manifestation. It is related to the paraneoplastic. The patient has to fulfill this criteria because all the skin manifestation um, will not include as a paraneoplastic syndrome with the primary malignancy. The initial criteria, both conditions begin simultaneously, the neoplasia and paraneoplasia, the development of the parallel course. The skin lesion is not associated with the genetic syndrome, and there is a specific type of neoplasia that occurs in the paraneoplasia, and the dermatosis is rare in the general population, and there is a high frequency of association between the both conditions. So our patient was presented with ichthyosis also, and primary carcinoma is a very rare presentation in our population. So with the what are the rare presentation of the paraneoplastic syndromes of dermatosis with associated neoplasia, acanthosis nigricans malignana with abdominal adenocarcinoma, acute pachydermatoplegia with gastric and pulmonary carcinoma, erythema geratum, herpes, pulmonary and esophageal and breast. During the course of the hospital, she developed worsening hypotension and acidosis and on second to this illness despite the intensive care. So after that, we found out that the postmortem biopsy we did for the primary for two founder. It came out to be the Hodgkin's lymphoma. The most common paraneoplastic syndrome the patient present with ichthyosis is the Hodgkin's lymphoma. But our patient didn't show any axillary lymphadenopathy and the palpation also. It didn't show any examination findings. So after the CT only we found out that she had a patient with the left axillary nodal mass. So in between during course of illness she went worse. So after postmortem biopsy found out that she has a Hodgkin's lymphoma.
Vivekananthan, can you go to your last slide? You're at 7 minutes.
So development of ichthyosis in the adulthood manifestation, systemic disease as associated with the malignancies and drugs and endocrine and metabolic disease and malnutrition and even autoimmune diseases. The Hodgkin's lymphoma is the most common malignancy reported with the acute ichthyosis. The pathogenesis of this ichthyosis is the transforming growth factor alpha secreted by the tumor cells. The improvement with the treatment of underlying treatment of the malignancy. Thank you.
Does anyone have any questions?
Well,
the biopsy it was benign. Benign.
benign.
And then you said bilateral upper limb weakness, bilateral lower limb weakness. What is the explanation for that? Doesn't neuropathy or something? Why? Bilateral upper and lower limb.
She was significantly emaciated and albumin was too very low. At that point in time, she was unable to respond to commands. It did not seem like it was the node. It was about 1.5 into 2 centimeters. That much.
Not clinically feasible.
He hasn't seen that patient. I had. She was significantly edematous. The other thing I had a comment on, when you put drugs for this patient, we do invoke drugs as a cause for ichthyosis, but if your patient wasn't on those